So we're very pleased to have as our next speaker Jean LaBerge from the University of California in San Francisco, and she's going to go into some of the changes in the training programs and how it's going to affect the relationship between us and our diagnostic radiology colleagues. Jean.
Okay, thank you, Gary, and thank you for inviting me to give this talk. It's a great opportunity to kind of inform everybody as to what's happening with this residency program. I should say at the outset that this is a work in progress, so I'd like to just kind of give you an idea where we are with this. I was asked in the title to talk about how it might change the IR-DR relationship. That's a question I'm not sure I could answer, so I've changed this to what is it, and then speculate a little bit about how it might affect things in the future. I should say, by way of background, that I'm a member of the Radiology Residency Review Committee at the ACGME, so I've been involved in the formation of these program requirements, and I'm also a trustee of the ABR, which originally derived the IR-DR certificate that led to this training program. So I'll try to give you some insight as to where we are and what it might mean for you. To start off with, let me just give you a little bit of background about how we got to this space. We've heard the term interventional radiologist used and discriminated it from a diagnostic radiologist. I think it's important to recognize that at least in part within the world of medicine, that distinction, the name, what it means, is derived from the American Board of Medical Specialties that designates specialties and subspecialties. And in 1994, the ABMS as an organization approved the subspecialty certification of vascular and interventional radiology, and they define, at least within that context, what an interventional radiologist is and what the domain of interventional radiology is. And since 1994, in the last 20 years or so, a lot has changed in interventional radiology, which is what we're all talking about this afternoon. The techniques, the procedures, the types of things that interventional radiologists can offer have changed dramatically since 1994. And also clinical care, you know, as Frank alluded to, we're not sure what that means, but it's become an integral part of interventional radiology. And by definition, within the IR-DR certificate and the program for training, clinical care then would be defined more specifically to be peri-procedural outpatient and inpatient care, longitudinal follow-up, and consultative services. And what this means is that the new certificate and the new training program recognizes that interventional radiologists are clinicians and they're responsible for peri-procedural, pre- and post-procedural care. They perform inpatient consultations, operate outside of the outpatient clinics. They admit patients. They provide focused clinical and longitudinal follow-up. They are clinical specialists that could provide consultative services for the items listed here that you're well aware of. So an interventional radiologist is a doctor, in short. So how did it turns out it was the SIR and the organization that went to the ABR to say this is what a high-level interventional radiologist is today, and we would like you to take this to the ABMS to document that this is what an interventional radiologist is. So they got the approval of the ABR, went to the ABMS, and the first proposal was to have a primary certificate in interventional radiology independent of diagnostic radiology. And that proposal was rejected uniformly by almost everybody on the ABMS, and the rejection came in the form of statements like inadequate training in diagnostic radiology and clinical care to support this, and that there's no demonstrated need for interventional radiologists to be clinicians, and that clinical care is an expansion of the scope of practice of the field. So the SIR and the focus team went back and redrafted a proposal that came out as what you now know today as an IR-DR certificate. This recognized, very importantly, that, first of all, interventional radiology was now different than it used to be, that it's a unique practice that involves as an integral part peri-procedural, longitudinal clinical care management of patients, and that is no longer disputed in the House of Medicine within the American Board of Medical Specialties. So in recognition of this, the ABR has asked the ACGME to design a training program that will prepare residents to enter this new practice which involves clinical care. So that's where we are right now. The ACGME is in the midst of drafting the program requirements. The purpose of this is to facilitate optimal patient care. So one of the luxuries of working for the RRC and the ABR is that I don't have to worry about RVUs. What I have to worry about is patients. The obligation of the two groups that I'm participating in, the whole focus of this is to provide superior patient care. And as I get older and my hair turns gray, I personally find this to be a very attractive focus. So, that's what this is all about. And what we want to do is provide trainees with the tools they need to be imagers, proceduralists, and clinicians. So, the key elements of this are more time. There's an extra year added to master all of the domain of interventional radiology, and there's a greater focus on clinical care. Although right now in our fellowships we do provide some clinical care, there's no definition, as Frank has said, as what that is. So we're trying to provide a better definition. We're trying to give a focus to the fellowship programs as to how to, or the residency, how to provide this. And in addition, we're trying to provide interested medical students with the opportunity to go into interventional radiology from medical school, and therefore have a longer period of time focused on interventional radiology. So the key elements are that these people that graduate will be fully competent diagnostic radiologists. They will be able to practice in all of the respects that were just mentioned as diagnostic radiologists, and that will try within the program requirements to give the institutions that are going to be making this change flexibility to figure out how to do this at their institutions. What this will involve is a clinical internship, 3 years of diagnostic radiology focus, 2 years of interventional radiology focus with mandatory outpatient clinics, admission services, consultative services, and an ICU rotation to get them comfortable with the kind of critical care that they'll be seeing. The one-year fellowships will be phased out over a long period of time, about 7 years, so that by 2022, there will no longer be fellowships and everybody will be in an IR residency. Now, just as a small explanation of this, it's been difficult for programs to do. So we're like the vascular surgeons, the thoracic surgeons, and the plastic surgeons, we've introduced the idea of integrated programs and independent programs. If you're in an integrated program, you go in through medical school, spend 5 years doing interventional radiology. But if you're a diagnostic radiology resident, you want to go into interventional radiology, you could enter a 2-year independent program after you finish your DR, or potentially if you're qualified, you could enter just the last year of the program. The thing to stress with this is everybody graduating from however they enter this are going to have 2 years, or the equivalent approximately 2 years of training, and it's going to be training that's focused on clinical care. This is just kind of the outline of how this will happen. For the, it's maybe more than you really need to know right now. But the question I was asked is how this is going to affect practice, and how will it affect the relationship. So I like to use this quote from Bill Gates, who's used to going through transitions. He said, "We always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. And I think that's particularly applicable to this particular situation. Residency programs are not going to be affected by this next year, but it's my fervent hope that 10 years from now, we're not going to be having to talk about whether an interventional radiologist should be in clinic or see patients or take care of them. It will be a natural, expected part of interventional radiology. So if you're in an academic program 10 years from now, you will have transitioned to an IR residency. You'll be able to recruit talented, interested medical students who could pursue a career in interventional radiology and do research during that period of time. That this peri-procedural longitudinal clinical care will be an integral part of training, so they will just be able to do that when they get out, and hopefully they'll be able to do a lot of research while they're in training. If you're in private practice, the expectation, and this is the defined expectation by patients, referring colleagues, insurers, quality of care organizations, is that you as an interventional radiologist will be a clinician and participate in multidisciplinary care and provide these services that are kind of defined as clinical care, and that your young partners coming into your partnership will be able to do this. They'll be able to build practices and start from day one. I take heart in the UVA experience. They've had this clinical pathway very similar to the IR residency. It's been very well received, and they've had a good experience with this. So what does this mean to the future of the IR-DR relationship? Well, it depends on the people in this room and the people that are coming to this meeting and the people in the society what this means. Organized medicine has made this change based on what the SIR asked them to do. The SIR said we are different now, we're clinicians, we have got to do this, and so this is done. It's been a very long struggle. The ABMS, the ABR, the ACGME have all made a huge change to do this for the request of the interventional radiologists. And it's a huge step forward, but what happens 10 years from now is very much dependent on what the young people in this audience do. What I have seen is that the old people, myself, old people older than me, over the age of 60, are very excited about this. And all these young people and medical students that are here, anybody under the age of 30, they're very excited about it. Anybody between the age of 30 and 60 comes up to me or sends me emails and they say, this is a great idea, but I can't possibly do this. Or could you please change this requirement to be this, because otherwise I couldn't possibly do this. It's very difficult to make this change. I don't want to underestimate how much trouble this is, but I think what I'd like to explain and what I'd like to get your encouragement and support for is the fact that although this is going to be somewhat difficult, it is extremely important. And if you're a patient being taken care of by an interventional radiologist, what you need is a doctor. So what we need to do is train these young people going into interventional radiology to be doctors taking care of interventional radiology patients, and that's what this is about. So thanks very much.